Welcome and thank you for joining our webinar today. The webinar will be starting in approximately 1 minute. Good afternoon, and thank you for joining RadSite's webinar, Cone Beam CT Imaging, Quality-Based Standards and Payer Reimbursement. Before we begin, I would like to go over a few housekeeping items. Today's presentation will be recorded, and an email containing the link will be sent to all registered participants by the end of the week. It will also be available through our website. To minimize noise and distractions, all attendee phones have been muted. However, if you have a question or comment during the presentation, we encourage you to submit it using the Q&A or chat box on the lower right side of your webinar bar. We will do our best to address all questions and comments at the end of the presentation. I will now turn the presentation over to our moderator, Mr. Garry Carneal, President and CEO of RadSite.
Good afternoon, everybody. Very excited about our first of 3 webinars for our fall series, sponsored by RadSite. Today's webinar will focus on cone beam CT imaging, and the relationship between quality-based standards and payer reimbursement strategies. I'm really excited about our speakers today. Please forward slide. It's my pleasure to introduce our 2 featured speakers. First is Christine Tackson. Christine is the founder and president of Link to Success, a dental management and consulting service firm that covers all dental medical billing training. Christine is a nationally known medical dental cone billing specialist. She speaks regularly in many different venues, leveraging her 40 years plus experience, and she excels at explaining complex billing and health topics to diverse audiences. Today, Christine also serves as the adjunct professor at the New York University NYU Dental School and Resident Program for New York City programs, and she also will begin teaching coding at Harvard Dental School. Prior to her starting her own management consulting company, Christine worked for large New York City hospital as administrator of a critical care department and managed an extensive practice and worked with coaching solutions of dynamic administrators consulting companies. In addition, Christine sits on several boards, including the National Dental EDI Council Foundation, as a founding member of the American Academy of Oral Systemic Health. And our co-presenter and reactor is Dr. Elliot Siegel. Dr. Siegel is professor and vice chair at the University of Maryland School of Medicine, Department of Diagnostic Radiology, as well as chief radiology and nuclear medicine for the Veteran Affairs Maryland Healthcare System. He is the director of the Maryland Imaging Research Technologies Laboratory and has adjunct appointments as professor of bioengineering at the University of Maryland, College Park, and as professor of computer sciences at the University of Maryland, Baltimore County. He's written over 200 articles and has made over 1,000 presentations on a wide range of topics, ranging from computer applications and imaging medicine, including, for example, artificial intelligence. He is a fellow of the American College of Radiology and the Society of Imaging Informatics and Medicine. And he also, perhaps most importantly for today's purposes, serves as Chief Strategy Officer of RadSite and is chair of the Advanced Diagnostic Imaging MEPA Standards Committee. Next slide, please. So today we're going to talk a little bit about the intersection between, again, accreditation programs and reimbursement strategies. And Dr. Siegel and I will start with just a very brief overview of RadSite, and then we'll turn over the presentation to Christine to talk a little bit about cone beam CT imaging trends billing strategies, some examples of billing codes, the importance of accreditation and best practices. And then we'll try to keep the session a little interactive. Dr. Siegel will make some comments and observations along the way. And then with time remaining, we'll take some questions. So next slide, please. So RadSite has been around since 2005. We actually got our start working with a number of payers, and believe it or not, we've actually certified over 60,000 low-tech and high-tech imaging systems at 25,000 provider locations. I have been the president CEO for 10 years, and most of my career has been devoted to accreditation. I've brought 25 accreditation programs to market over the past 25 years as well. So we've been able to leverage kind of my accreditation experience, and the administrator of today's webinar, for example, Julie Irons, has also been with me for decades, helping me with the accreditation programs. But today, starting in 2013, RadSite began to focus on advanced diagnostic imaging accreditation. And we offer 5 different accreditation programs today, one for CT, one for MRI, one for nuclear medicine, and most recently, dental cone beam CT and medical cone beam CT. In fact, after 3 years of development, we got approved by CMS earlier this year for the 2 new cone beam CT accreditation programs and just announced our first wave. So we're very excited about that. RadSite's also a research-based organization. For example, you're about to hear about a strategic alliance we're entering with the Radiology Society of North America, where we're going to help the Quantitative Image Biomarker Alliance beta test some biomarkers related to cancer. So stay tuned for that. Next slide, please. So Dr. Siegel, why don't you tell the webinar participants a little bit about kind of our journey with the cone beam CT accreditation program?
Sure, Gary, I'd be happy to. One of the things that's really important to emphasize, as you all probably know, is that cone beam CT is really fundamentally different in a number of different ways than non-cone beam CT. And one of the ways that it's different is that cone beam CT has a different profile of practitioners, including dental, ENT, maxillofacial, musculoskeletal, orthopedic, and podiatry applications. And also there's fundamentally a significant difference in the physics, the strategy for image reconstruction, and particularly in the assessment of image quality and even in the assessment of radiation dose. So we've been meeting and have had input from a wide variety of different stakeholders, including a couple of world-class physicists who we've engaged to look at what are the optimal ways to be able to actually look at quality for cone beam CT, and also to look at measuring doses. And so the standard that we have has been under continuous development for the last, I think, 3+ years. And there was some beta testing of the standards with actual sites with feedback that was done last year. And in the spring of this year, CMS approved the version 1.0 version of the cone beam CT standards that we have. And the first wave of sites was announced just last month in September of 2021. And the standards, as I mentioned, cut across both dental practice, but also multiple different medical areas where cone beam CT is used in particular. One of the things that I'd like to underscore is the fact that there is a version 1.0, which is the current standard, and that emphasizes the manufacturer's own phantom testing. And so given the fact that there really is not an agreed upon standard that exists currently, either by the American Association of Physicists in Medicine or any other particular industry group or CMS or the payors, the initial requirement is to meet the manufacturer's own testing requirements and to ensure that the system continues to pass those. Presumably, the manufacturer was able to get the equipment FDA cleared, and presumably that suggested phantom testing process is one that allows one to be able to determine whether the system meets at least the requirements that were shared with the FDA initially. But the direction that we've been heading has been in this future version that we'll call 2.0, which is uniform phantom testing. And so there's a phantom that's pictured here that we're hoping to use moving forward called Corgi, although there are multiple different phantoms that presumably could be used for cone beam CT standards. But the idea moving forward is to have a single standard that all cone beam systems would be compared against. It would allow us then to compare the features of one cone beam CT versus another with regard to a number of different quality metrics and parameters. And so I'm particularly excited about the ability to compare cutting across different systems. And I think the superior systems that are out there, whichever ones those are ones that we would be able to identify with a uniform phantom testing process. And what I'm hoping is that it can continue to raise the bar for image quality as we're able to compare across multiple systems and have a systematic and objective data-driven mechanism for assessing quality, and also parenthetically for assessing a dose for a cone beam CT. So thanks, Garry.
Thanks, Dr. Siegel. Next slide, please, Julie. So when we look at kind of the accreditation framework, there really is a pretty rich tradition of using accreditation to supplement regulations and purchasing criteria, quality initiatives, outcome measures. And this slide kind of just gives you kind of a laundry list of different things. Obviously, accreditation can improve accountability. It can provide education both to the accredited company and to other stakeholders. It can promote evidence-based pathways, basically put together process and structure measures to make sure there's consistency in terms of, in addition to the uniform phantom requirements, in terms of clinical oversight, et cetera. And there's the issue of performance and outcomes, and just the general business continuity arrangements. And I think back, the very first accreditation program I brought to market was back in the mid-1990s, and we had moved from indemnity insurance to HMOs, and something was coming on the scene called point of service plans. And those eventually became known as PPOs, which are now the kind of dominant kind of network delivery system in the United States. But back then there was no regulation. So the accreditation organization I was running really put together the first process and structure measures, and then later some of the outcome measures that kind of really launched our ability as a society to offer PPOs. And I kind of see this as kind of similar related to cone beam CT as emerging technology. It certainly has a lot more penetration in dental offices, and it's more of emerging in terms of new installs in medical offices. But it's something that I think this accreditation program can really fill some important gaps. And if you want to learn more about the actual standards, we do, RadSite offered 3 webinars last year on cone beam CT. You can go to our webinar page and you can listen to those webinars on demand. And if you want an update on what we're currently doing, you can register for our next webinar in November, which will be given an update on the cone beam CT accreditation program as well as the traditional MAP program. So lots of reasons to think about accreditation as we kind of queue up Christine. So go ahead and forward the slide, Julie. And Christine, we'll be happy to turn it over to you. And we're looking forward to learning a lot today from your perspective and insights. Thank you.
Hold on one second. I didn't know I was. Thank you very much, Garry and Dr. Elliott, for having me be able to be part of your organization. It's been a long time coming, and I'm so excited. Billing for the CBCT scan has been a quandary within the dental community because the companies that sell the units didn't have the background that like Dr. Elliott had and has, or the understanding that you're purchasing a medical piece of equipment. And when Dr. Elliott and I do speak about this, it is really important for us to understand the reason a CBCT scan is now in your office, because most medical doctors do not have a CBCT scan in their office. Most refer out to a radiology facility. So when you think about radiology facilities, whatever we do at a medical doctor's office, whether it's a mammogram or an x-ray, most of us are sent to a radiology practice to have those tests done. So I want you to keep that in mind when you're listening to why it's important to know the rules, to know what you can do, and why credentialing is so important within all of this. One of the things I get asked every single day is, what is the law for me? Can I do this? Can I bill medical? And the answer is yes. So in 2014, Medicare came out with a new law, which nobody understood why all of a sudden Medicare was asking us to, send in applications to work within the CMS organization. It wasn't so much that you had to be a network. It was because, according to the new law, you are a definition of a physician and practitioner. So for purposes of medical billing, you were added into this legitimate federal government law that helps back you in the medical billing world. Next slide. So what we have here is that health insurance really has also understood that dental and oral surgeon scope of practice. So even the endodontics has added cone beam as a part of their organization in becoming the scope of that type of practice. Why? Because they can care better for their patients, have less problems afterwards, and it's better for the patient in an all-around medical billing. So when you look at the new law that just came out now, when the federal health care law passed, the first one, this one also passed and said a group health plan and a health insurance insurer offering group or individual health insurance coverage shall not discriminate with respect to participation under the plan or coverage against any healthcare provider who is acting within the scope of a provider's license or certification under the applicable state law. So for instance, you're practicing in Maryland. In the Maryland state law, your license is provided so that you can practice. Once that license is a part of the state law, then this health insurance will back you to be able to bill medical and perform anything within the scope of your license. So let's think about how big the scope of your license truly is, because most of us never really think about that. But here I have two examples. A neurosurgeon uses the same exact extraction code as a general dentist. And also a dentist performing bone graft bills the same exact procedure as a plastic surgeon performing a bone graft. So what does that mean? That means that a lot of our GP dentists today, in the world of today, are doing more and more training after school than they did in school. So that means that they may have a specialty that will apply to the billing and the coding that is being done in today's insurance world. We also can apply the reason why they are purchasing CBCT scans to be within their practices. So we have an opening here that's putting us within the healthcare scope of practice. Okay, you could go. So a positive approach towards this is really what you need. And I've been teaching medical billing for a really long time. And there's a couple of things that happen. We purchase these supplies, whether it's a CBCT scan or a laser. I don't really care what you're purchasing. There's a set of guidelines that we must follow. But you have to remember that the company selling you the product may not know all of those rules. So working with people that have that ability will help you fine tune your process. But if you're in this world of, I'm going to purchase the machine, I'm just going to do these CBCT scans for my patients, everybody that walks in the door, somewhere along the line, that could be detrimental to your license. And that is something that I try not to say because I want to use positive words. So I'm going to show you when you do positive words, when you're treatment planning and letting your patient know the importance of this radiology and what the patient is saying, it's going to affect everything that goes on in your office, both on treatment planning, the acceptance of treatment planning, the legalities of the billing, and knowing you are staying within the scope of your license, because patients are not understanding that. The first thing they're going to say to you, even with a radiology test, if you're not reading it the way a radiologist is reading it, then there is nothing for the patient to understand. Because in dentistry, we have a habit of talking about what we see and not what we are finding by using that radiology report. And when you're reading the radiology report, according to the scan that you take, you have to remember that everything within that scan must be documented, and you should be able to hand that report to a patient if they ask for it, because that will help them be ready, not where you're telling them why they need it and they don't understand why. So patients will say, I'm not ready, it'll cost too much, are you sure I need this? Can I read the report? Because they need to know. And I'm going to say something that, you know, in the world of medicine right now, people are very leery of being told what to do. So not telling them and explaining it and showing them is going to really benefit you so much more than when we look in the oral cavity and say, you know what, I see this tooth is fractured, that you're going to need a crown. Well, even if you have an intraoral camera and the patient has a tongue in their mouth, they know that tooth's fractured. But what you say to them about why it should be treatment planned, why does it need to be fixed, how would you fix it, and what else is going on. But the biggest thing we don't ask is, how did this patient end up this way? Because a fractured tooth doesn't just happen unless there's a trauma. A fractured tooth can happen if that filling was a very large filling and you bite down incorrectly and it fractures the tooth. Or the patient's missing 6 teeth already. How did they lose those 6 teeth? So we have a lot of different questions that we should start asking our patients in a very positive way so that we can get them ready to say the word, yes, I know I need it, and how can we make this work? So let's go to the next slide. So what you have to remember is that a diagnostic test is used on an everyday basis in hundreds of offices, not just yours, not just a medical, but hundreds of different types of providers in the country. It's a diagnostic tool. So how do you use this tool to help you make sure that you are treatment planning the patient back to function and back to health?
And Christine, as a radiologist, could you give me a little background? In other words, what percentage of practices have cone beam CT already? Is it becoming community standard at this point? And of the practices that have cone beam CT, how many of them are doing, what percent are doing medical billing? So,
okay,
maybe
so that's a good
how prevalent is cone beam CT out there right now? And of the places that have cone beam CT, how many are doing medical billing versus just non-medical billing?
If they purchased a CBCT and did not have training in the setup and the way of billing, because dental does not cover this. There's only one dental insurance I even know that covers this. And so I could say 50% of the doctors that have a CBCT have been trained, not just by me, but by, you know, there are some other companies out there. The big difference, 50% out of the doctors that own a CBCT scan. Okay. Some have been given the wrong information in the beginning, or they're purchasing billing from a company when they're purchasing the equipment. And that is not really beneficial to the practice.
Okay, and of the ones that are not doing medical billing, do you know is there any trend or typical charge when they are not able to do medical billing, and what are people collecting for the cone beam CT? Is it comparable to a Panorex, or how are people charging, or is it pretty much all over the board?
Okay, it's all over the board. Some are doing it for free because their patients refuse to pay for it, so they won't have it. They ask for medical billing and the offices don't want to be bothered, or they're having another company do it for them, even if they own one and the patient gives them grief. So yesterday I had a conversation with a doctor who is charging $450 for the film, for the scan, and the patients refuse. They say it's too much to lay out without anybody trying to reimburse. And he called me yesterday and he said, now that he knows how to get it reimbursed, not one person argued with him in the last 2 months on why did they need that CBCT scan. And he is ecstatic. So I'm seeing a lot of doctors really seeing the benefit of medical billing because of the CBC. I have endo doctors. Endo has never been a billable procedure under medical. And in today's economy, they're all billing under the insurances, the exam and the CBCT scan. And according to the treatment they're going to provide, whether if they're going to open up an abscess, they're billing that to medical. If they're doing a root canal through the tooth, you can't bill it that way. But they're billing a lot of other services now, and they're all becoming amazingly happy. And ortho is also a very big proponent on medical billing for CBCT scans.
And
so it's happening.
And is it just CMS that is reimbursing, or do most medical insurers?
Oh no, all medical is reimbursing.
Okay.
The difference between regular indemnity medical, whether it's a PPO or completely private, and then Medicare is the leader in medical billing because they made that first law that we could bill medical. And then the second thing that happened is most insurance companies will follow Medicare in what their guidance. They did it with sleep apnea, and now they're doing it with CBCT scan. They want the machine to be certified in order to bill.
Thanks.
And so now many states are now requiring
it. And Christine, how about follow-up? In other words, a pre-procedural cone beam CT, are there rules or regulations about getting follow-up studies post-procedure or after some period of time? And have you or your practitioners had any experience with more than one cone beam CT on a patient over time?
Well, I could tell you that if you're doing an implant, whatever type of implant you're doing, it doesn't matter. You could take a CBC, you could make a stent with the CBC so the lab could place, help you place that implant in the correct position, and then you do follow-up. So you could take up to 3 for one procedure, because in the medical world, I use this analogy. If you fall and break a leg and they have to cast it or do surgery on it, they're not going to do that without a film before, then during, sometimes even during the surgery, they're going to make sure it's placed in the right position before they cast it or put it in a brace. And then they're going to do follow-up before they take it off. Because I worked in spine surgery, and they're never going to do a spine surgery without several CBCT or MRIs. They're just not going to do it. So there's no ruling on how many. It's different than dental, where you're only allowed to take x-rays so many times a year. A CBCT scan is treated the same way throughout all the medical community, including us.
Thanks, that's interesting.
So that's a really very good thing, because the doctors have much more an ability to work with the patient throughout that surgical procedure, whether it's bone grafting, implant, or even surgical extractions. This is standard of care in endo, and it's becoming standard of care in ortho, and you're going to see implants are going to be the next, because very few of those are placed in the right position, and they're being taught more and more when they take implant courses to place those implants in the temporal mandibular way, not straight up and down, which is the benefit of a CBCT scan and a stent. So it is standard of care in a lot of instances. So it's really changing the way we practice.
Yes.
Totally. But you have to pre-certify. And doctors always ask me, and I love questions because I learn every single time. So when I first started teaching this, I was at a big CBCT scan meeting, and somebody came over to me and said, well, how do I pre-verify or authorize a CBCT scan if I don't know why I'm taking it? And I said, well, the first thing your office has to do is get information as why were they referred to you? Are they in pain? What kind of pain? Because signs and symptoms of that patient become the pre-authorization diagnostic code. So a lot of my TMD doctors, whether they're doing Botox or myofunctional or an orthotic, pain or opening and closing and clicking can be signs that you could use to get that pre-authorization. Because how do we treat somebody if we can't see that condyle bone? How do we treat somebody without knowing it's TMD? So the insurance companies will pre-authorize those pretty quickly. If the patient's in pain and they had a trauma, you don't even need to pre-authorize. You just take it, and when you bill it, you give them the trauma trauma signs. But you can pre-authorize before they come in most instances, because you're getting that information from the patient, which also helps you document better. So there's a lot of reasons why I've changed the way 90% of my dental practices even answer their phone. I mean, I don't want you to talk about a lot. I want the patient to tell us why they need us and what's going on. And a lot of them, even if they're not in pain, they're going to tell you, well, I'm missing teeth and I heard you did implants and I'm interested. Well, get that pre-authorization. If they're missing teeth, they have a problem. They cannot chew and swallow. So there's a lot of things you can learn just by listening to what your patients say. And when I teach you how to diagnose, you're going to see there's a lot of codes that are not used for payment, but are used for that pre-verification and the starting point for you to get paid on those CBCT scans. So next slide. You have any other questions, Dr. Elliott?
No, you did a terrific job. Thanks. That's really complete and really clear too. So thanks. I'm sure I'm going to have plenty more, but
no, that's good. That's good. Okay. So why can we do this? Well, let's look at the mouth, the jaw, the neck, the ENT part of it, ears, nose, and throat. That's why ENTs and oral physicians really have a strong connection. And I find it very enticing when ENT and the oral physician works together, because they work together in a lot of cases because of clicking, pain, opening and closing, or ear pain. That's not really ear pain, but coming from the opening and closing of the condyle bone. Or they go to an ENT because their nose hurts, but they have an abscess up on the top of the oral cavity, or there's something there that the ENT doesn't like what he sees and wants to have a CBCT scan taken. And I've been part of many of those cases, but we have so many things that we need to look at. And the fact that we have this ability is really helping us move in the direction of better and better treatment. Dental implant planning. Can't really do it well without a CBCT scan. The visualization of abnormal teeth or placement of abnormal teeth, the evaluation of the jaws and the face, the cleft palate assessment, diagnostics of dental caries, endodontic diagnosis and diagnosis of dental trauma, bone grafts. How much, it's funny because bone grafts are not even covered by dental anymore because they consider that 100% medical procedure. Temporal mandibular, 90% of the states have a law on the books saying temporal mandibular is medical billing. Do not bill dental. But a lot of people don't know that. So they're getting paid for a bruxism plate versus an orthotic. That's a big difference in financial. And then sleep apnea. Sleep apnea in ortho is huge right now for children. And one of the things, they always take a good SEP because that's how they treat and plan ortho. But now they're taking a soft tissue neck so they could see the airway before they start treating, because that will make a difference in whether that doctor is going to bill dental for ortho or medical for ortho. So the palate and the soft tissue neck area are taken so that they can really treatment plan that child into whether it's medical or dental billing. And that has been a huge benefit for a lot of people, because there's kids with sleep apnea or their jaw is not big enough for their tongue. And so they're billing TMD treatment by expanding that palate, or they're putting an expander in for the sleep. So this is all medical billing now. And it's great. It's just really great because it's helping so many people that we did not have the ability to see or diagnose without the CBCT scan. So it's exciting. So go ahead. So what are some of the signs and symptoms that we were just talking about? Just so you know, they come in Chapter 19 of the diagnoses. When I teach the dental medical billing, I don't use the whole medical book. In fact, I work with a company now that we have a diagnostic book with all the diagnostic codes dental could use. So for example, dysphagia, it's really difficult swallowing. If you're missing a lot of teeth, it's very difficult to swallow and chew. And what we're doing in pedo practices or ortho and the older generation is to watch a patient sip water. When they go to sip water right by the chair, you could actually see if they're swallowing it with ease or they're trying to push it down. It's one of the signs that they have a problem of swallowing, and it's usually a sign that they have either very dry mouth or they have a smaller jaw. So it's really interesting. Atypical facial pain, it doesn't have to be specific. Any trauma, and now halitosis. Because during COVID, we're wearing masks for 8 hours a day, there is a new diagnosis out called mask mouth. And mask mouth is halitosis from not breathing in and out the carbon dioxide, not having the ability to swallow and chew during the day without mask removal or going into a place. And so it's a really big deal because halitosis is a sign of infection. And so we have to be very careful, even with that arena. And sometimes patients don't know they have halitosis. So we have to be really honest about that. You could go. Referrals. Imagine the world of collaboration with all medical and all dental offices. I see it happening in several ways. 90% of the Medicare Advantage plans, which most offices are still learning about, cover dental. It may be dental billing or it may be medical billing, but they cover dental. If that's the reason the patient is buying into the Medicare Advantage, because they want dental, and medical is saying, we need you to have that treatment so you could stay healthier. Endocrinology is understanding the need to refer patient to the oral physician, and the oral physician now having the ability to do a finger prick blood test, not to diagnose the patient, but to see if they have any kind of diabetic signs and symptoms, to send that patient to an endocrinologist, because that is the biggest illness in our country that is affecting the patients of today. The overweight, obesity, and diabetes is killing more people than any other disease. So having that collaborative effect is really helping. We talked about ENT, but we also know that headaches are part of Botox, biofunctional, and TMD. So don't rule out the fact that you could become a collaborative, interactive referral source for many medical procedures, whether it's sleep, whether it's ortho, whether it's endo. We are seeing a larger amount of people working together to get their patients healthy. I just helped the first practice ever to work together in Chicago. They have a wellness center. The wellness center includes not just an oral physician, but a medical physician, a nurse practitioner, and hygienist working together, so the patient has, with a CBCT scan for all of it, so they can make sure that their patient is getting the best health treatment. And you're going to see a lot of that happening in the near future. You could go. So we talked a lot about these people that are doing it. Just so you know, last year during the COVID, they actually designated a new specialty within the oral physician, and it is specifically as an oral physician caring for patients that have a lot of systemic issues. They would never treat a patient now at the Ford Medical Center in Detroit unless an oral physician has a full CBCT scan, knowledge of what's going on with that patient's head and neck, making sure they have no infections prior to any other treatment within that hospital. They have really taken collaboration to the next level. But I'm going to tell you, pediatric offices are using CBCT scans because the development of that facial head and neck is what we can stop things from happening if we know it early enough. And pediatricians work very closely with orthodontics, but they're now working closer with ENTs and perio more and more, because they understand that the child is changing on a daily basis. Growth is important, and managing that growth is important. Also, people with disabilities. it's so much better for us to take a CBCT scan so we could see everything instead of putting them under taking a full mount series of x-rays with like a Down syndrome child can't even endure or can't sit for. So there's a lot of areas of specialty using this, not just for surgical procedures, but for almost everything we do in the oral area. So I'm excited that they're doing it in so many different areas. The one thing that you do need to know, and why I recommend getting certified so much, is there is a difference between pediatric CBCT scans and how they're written, and then how the rest of us, the adult treatment, is being taken and written. So there's certain consent, certain radiation parameters that have to be followed. And it's one of the reasons why working with Dr. Elliott has been a joy for me, because he definitely knows all that. And I've learned a lot from him on that arena. But the rules of billing for that particular group is different than everybody else. So just make sure that when you do your credentialing, you get all of the pediatric stuff so that you have that available to you. Okay. You could go. So medical billing allows more patients to say yes. You do not need to work to be in network. You don't have to be in network. That's a fallacy even under Medicare. You do have to have your NPI and your license and all those things on record with medical plans. But being in network is not a requirement unless it's an HMO plan, which that's your choice. I have doctors that do Medicaid CBCT scan billing or Medicaid implant billing, but I have no need, even with Medicare, for you to be in network. So I want to make that clear. But you need to be trained on how to get your office set up so that it's compliant, following the regulations and the rules, the standards of care for all of the things we talked about, and accreditations. And we want to make sure that you have all that. The reason being is if you are going to understand that you're no longer there is no longer that little mom and pop dental practice. There's very few of them. And so if we want to grow, we have to grow in other ways to be in the compliance arena. We have to understand the policies. We have to have a certified radiologist information. We have to protect our documentation. We have to be able to bill correctly. And yeah, that's what scares 90% of the doctors, Dr. Elliott. They don't want to be bothered with requirements. They just want to take that film. So they think taking it for free is okay, but it's not. If you are audited in any of the arena things that we do, and you have not put something into the documentation, or you added the CBCT scan or the laser treatment or whatever you're doing into the patient's documentation, but you didn't bill it without a signed consent from the patient to say to you, I don't want it billed, then you have another problem. So we could really learn that. I can't teach that in this amount of time, but I'm having a course online next week before our meeting on how to set up your office to be able to bill, and it will go into depth why Medicare requires you to be accredited. That's the only requirement. You do not need to be a network. You can become a non-participating provider, but that's Blue Cross now follows everything Medicare does, and so do some other insurances. So it'll open up your arena to all medical billing for all of your CBCT scans, no matter what you're taking it for.
Christine, one thing I find interesting is as a medical practitioner, we can essentially get into trouble, as you said, by underbilling or not billing. If I provide services in my radiology department, for medical care and do medical billing, whether it's CMS or others, but particularly CMS, if I provide a study and don't bill for it, then that's also considered to be against the Medicare rules, and there are penalties associated with that.
Yep.
So there are. Interesting that it's so prevalent currently in dental practice to do the studies and not bill separately, because on the medical side, we would essentially run afoul of CMS by either underbilling or not billing.
Right, and that's a major problem in billing any of these things. But the problem is, doctor, a patient can say today, I don't want you to bill my insurance. That's perfectly fine. But that doesn't mean the doctor that takes the film shouldn't document it. They have to document what they see, and they're not doing it. That becomes a major issue. On top of, if you think you could take it on every patient that walks in the door because you purchased this to help you, treatment plan, you still have to document it. And when you do it for free and they have insurance and you haven't gotten that one form signed by the patient, that's a major issue. So just so everybody understands, when you are dealing with insurance companies, there are laws. You cannot make more than your private fee, no matter who you bill, but you can bill 4 insurances, as long as you don't go over your fee in your office. The second thing is you can't not bill for it for this patient and then bill for another patient. That's discriminatory, and it's a compliance issue. The third thing is that when you have the ability to take this CBCT scan and you're taking it but not billing it and not documenting it, and somehow this patient gets ill, that's a lawsuit waiting to happen. So there's compliance laws around the billing, and then there are requirements around the liability of your patient, the malpractice part. So we have to know all of those things.
Thanks. And when you say using a certified radiologist will provide protection, I assume you mean a board certified radiologist, but one of the things I'd like to emphasize is that the subspecialty of radiologists that would be most pertinent would be neuroradiologists. So I would recommend that people consider those radiologists who have additional training or comfort or expertise in neuroradiology, particularly given the region of the body. I think it's okay to use a general radiologist, and I know many general radiologists read a large amount of neuro studies, but I think all other things being equal, having a radiologist who has particular specialty in neuro imaging would be optimal.
And I agree with you 100%, because the way they write a report versus the way an oral surgeon or oral physician writes a note is like night and day. And when I teach at the universities, this is something that I've been preaching. I feel like I'm a mother hen. When I teach at the student level, they are documenting a novel. Then they get into a practice or they're doing, oh my God, what's that? I can't think of it. But anyway, they go into like a hospital to work or whatever. They're not documenting, they're text messaging. So because they are now under pressure to see more patients, but you have to document a lot better than you are. But the radiology part, if you can't read that film properly, and especially in the beginning when you first acquire it, send it out to be read, because billing a CBCT scan is, you have the ability to still bill for taking it, and they can bill for reading it, or you can work together. There's a lot of ways of doing it. I mean, there's no reason that you feel like you have to read it until you know you've taken courses from somebody like Dr. Elliott and become somebody that could read those tests. And I'm not saying it can't happen. I'm just saying when you first start, why would you take that on? There's enough to deal with.
Hey, Christine and Dr. Siegel, this is an amazing discussion. I just want to give you a heads up. We've got about 5 minutes. We have received a lot of good questions. So maybe what we could do is, if you could, Christine, kind of wrap up we'll run a little bit over time, and maybe answer the questions after the hour. But I just want to give you kind of a time check, but amazing discussion, obviously worth much more discussion. Very, very helpful.
Okay. So why don't we just go to the next slide, because I want to show them the way to write it up. You could go. I'll go on. Next slide. I want to show you, no, go back to the slide just before it. Why provide, no, there, that one. CT imaging scans are common diagnostic tests to take in all types of injuries and illnesses, and Medicare covers diagnostic tests under Part B. I work with a Medicare specialist who will help you understand that you can become a non-participating provider, bill for under Part B, and be able to get paid for it. And Medicare Advantage plans cover CT scans as well. So cost in CBCT scans, this is a question I get asked every day, what should I bill? That is in part of where your zip code is. And we don't have time to go over that, but anybody that has questions can feel free to email me and I'll try to answer them on how do you set up your fees. So why don't you go over the questions then, or the accreditation of it.
All right, why don't you, Julie, go to the next slide. And Christine, if you could just address a little bit so obviously CMS recognized RadSite as part of its MIPA accreditation program for cone beam CT imaging. And so clearly that's straightforward. We did receive, for example, one question about high deductible health plans. Obviously not all insurance benefit levels are the same. So how do you kind of deal with something like a high deductible health plan? I mean, that's probably the same issue between cone beam CT image and any other type of image, because a deductible is deductible, but how do you deal with those kinds of issues?
I'm going to say this. This is what I teach the billers. If you're going to take a CBCT scan and that's what you need to take it. But if there's a high deductible, what type of case are you going to be billing? Because a dental plan only has $1,500. And if you're taking a CBCT scan because you need to do an implant case or TMD case or anything over the deductible, then so what? That patient has to pay that deductible no matter who they go to, even if it's an in-network doctor. So if you're going to do a case over that deductible is going to be eaten no matter what. And you then have the ability to bill the dental, which really very little dental bill pays for CBCT scan, or the office visit or whatever didn't get covered under it because you didn't collect any money. So there are so many ways around it. And if it's an emergency, they're going to pay for the CBCT scan most of the time. So it runs differently than dental. They don't take the deductible off of everything. They have certain things that are not under the deductible, and every insurance is different. So that's my answer.
Great. The next question is, what would you tell an office that has TMG general dentist and a perio dentist in terms of what would the first step be? And I'm not sure I fully understand the question, but how do you get set up?
Well, you have to, if you have a CBCT scan in your practice already, I would do 2 steps at once. I would start the credentialing process if you haven't been credentialed yet with the CBCT scan. And at the same time, I could work with somebody teaching them what we need to do to set you up. in many ways. If they want to bill Part B, we'll set you up. If you don't want to bill Medicare, that's fine, but you have to have the forms to give patients to say, I don't bill Medicare. But you're leaving out a huge population because Medicare Advantage and regular Medicare require you to have something in there. And you're losing a lot of people because they're buying it for treatment within the oral physician. So I'd be happy to set you up with a 1, 2, 3 kind of process if you want.
Right. And how do you get around some federal, for example, Blue Cross Blue Shield plans do not pay for dental services? So can you, in those cases, also bill through the medical codes?
Can you say that again? I didn't
Sure.
understand.
Some federal health plans, I guess through the Federal Health Employee Benefit Program, do not cover for dental services. So in that case, could you also, in terms of a federal employee, bill under a medical code to get coverage?
Yeah, they can if it's a medical necessity. Absolutely. You have to know what insurance is. So I have TRICARE, for instance, which is a retirement. I can't remember what organization it is, but it's federal. And you have to get permission from them to do treatment. So I know that I've gotten permission for patients that came into our office, and we were not in network with that plan at the time because we weren't billing medical. But when we started to bill medical for sleep and TMD, they gave us a specific waiver for those procedures. And that worked wonderful. So every company wants to work nice, unless you get somebody on the phone and you never accept that one person on the phone, because that person's trained to scare you. But you have laws now written by the federal government to use to help you get them to agree to letting you see these patients. Look at the veterans are sending patients out to regular doctors and dental offices.
So we have lots of questions coming in. We're a little bit over, so I'll go ahead and make sure we respond to all the questions coming in. The one last question which we'll take is, do I need to purchase a special Phantom when version 2.0 comes out? And I can answer that. So currently RadSite does default to the manufacturer Phantom, and RadSite, for example, in the Advanced Diagnostic Imaging Equation Program will recognize any commercially available Phantom. So when the day comes a year or two from now that we're defaulting to the universal Phantom, which I think is something payers are going to expect, just like they expect now for traditional advanced diagnostic imaging, physics testing. We'll certainly recognize any commercial Phantom out there that has kind of evidence-based, to it. So we'll cross that bridge when we get there.
Plus, there might be the possibility of borrowing or renting or leasing a Phantom or having it some other way without the practice necessarily needing to purchase the Phantom. And Garry, just one more question to Christine. Christine, you mentioned that you've got a conference or seminar coming up in a couple of weeks. Could you just let people know how they could find out more about it?
Yeah, I'll send you the thing. I'll send it to you, Garry, and then you could send it to everybody. How's that?
Thanks.
Absolutely. Julie, if you want to skip to the last slide and let's go. I mean, obviously we need to do some more webinars on this topic because there's a lot to cover. I want to thank Christine for amazing kind of initial perspective, but RadSite's again excited that through its dental cone beam CT creation program and the first standalone medical cone beam CT creation program that we're going to be able to work with payers. In fact, RadSite currently is working with the National Alliance for Healthcare Purchasing Coalitions and doing kind of a national study looking at how payers do look at cone beam CT, and just really the same way going back to the beginning of my career where we worked with payers to explain what a PPO was. We have an opportunity now to really kind of take the momentum that Christine has created along with the standards to really kind of push the ball forward. So at the end of the day, it's about the patient. And Christine, I think to your point, making sure that we have the right diagnostic imaging at the right time. So thank you both of you for a wonderful presentation. We're going to have to schedule some more of this. Christine does have a number of different webinars that she offers, and a big meeting coming up next month in Florida. So we'll send all the information out about that. Julie, do you want to wrap up? And again, thank you, everybody.
And thank you so much. And thank you, everybody, for your questions. I'll be happy to answer them when I receive them, sometimes a day later, but be patient with me.
Thanks. Terrific job, Christina, making it really clear and really understandable.
Okay.
Julie?
Thank you both. And just a reminder, today's presentation has been recorded, and all registered participants will receive an email with the link to it by the end of the week. It will also be available on our website. And if you enjoyed this presentation, we have 2 more presentations scheduled. The first is RadSite Standards and Accreditation Updates, 2021 Annual Update, and What to Expect in 2022 on Wednesday, November the 17th at 1:00 p.m. Eastern Time. And the second webinar is Promoting the Patient Experience Through the Integration of Leadership Values, a spotlight on outpatient imaging centers, featuring David J. Waldron, CEO of Traction Business Development. And this is scheduled for Wednesday, December the 8th at 1:00 p.m. We hope you will join us for both of these webinars, and we thank you for your participation today.